So, bonjour, mesdames, messieurs, bienvenue. Thank you so much for joining us on another edition of our University of Ottawa Heart Institute weekly conference involving experts here at the Institute as well as around the city and elsewhere. And so appreciate your joining us in a few logistics, which I'm sure most people are very familiar with. And that is that if you have questions, please post them in the Q&A feature on the bottom of your screen as the lecture is in progress. And we will also be able to have live questions at the end of the lecture as well. And so please use the hands up feature and we'll unmute you and bring you into the panel. And if you have any technical issues, please use the chat feature. And then Kelsey will be able to make sure that we can overcome them and have you join us in an expeditious manner. And we're absolutely delighted today to have Dr. Darryl Davis to be our honored guest lecturer. And folks will know that Dr. Davis is a clinician-scientist and professor of medicine at the University of Ottawa, as well as the Heart Institute. And he's attending physician in the cardiac arrhythmia service with responsibilities including cardiac devices and also ablation. So he's a super busy clinician, but he's also the director of research for the Division of Cardiology. So he's indeed one of these very rarefied special individuals who truly can work from the bench to the bedside and really influence clinical practice in the future. And Dr. Davis graduated with BSc back in biology and pharmacology at McMaster University, and subsequently came to Ottawa and obtained his MD as well as a specialty training in electrophysiology here at the Heart Institute. And his program of research focused on the implementation of biological therapies for cardiac arrhythmias and heart failure. And he did this way back when he was a postdoctoral fellow with Dr. Eduardo Marban, and I think it was at the Hopkins at the time, when he developed the special cardiosphere-derived cells for ischemic cardiomyopathy. And since then, Dr. Davis' lab has explored the therapeutic potential of explant-derived cells cultured from human heart tissue through a biopsy, for example. And recently, it developed serum-free and the xenogen-free techniques to isolate clinical-grade extracellular vesicles from these heart biopsies. And this is enabled by the ability for these vesicles to reduce cardiac fibrosis and inflammation, and a lot of features that we look for in terms of therapies for the heart. And the recent success in the CIHR and UNSER grants really allowed Dr. Davis to explore further the therapeutic potential of these extracellular vesicles to treat atrial fibrillation. A portion of this work has already been published in several high-impact journals, including Nature Communication, Stem Cells, and European Heart Journal, amongst others. And he's also active in many clinical trials exploring the therapeutic potential of biologic therapies. Examples include the CardioAMP HF and the Concord-1, as well as ENAC-AMI, and some of which he will elaborate on. So it is really actually with much anticipation, we look forward to Dr. Davis' presentation today, entitled Prevention of Atrial Fibrillation After Open Chest Surgery with Extracellular Vesicular Therapy. So the floor is yours, Darryl. Thank you so much.
Thanks, Peter. Thanks for that introduction, and thanks to people for attending this seminar. I can't think of anything more boring than to listen to a guy talk about atrial fibrillation for an hour. So I appreciate people attending.
Oh, be careful.
This is what I do.
Birdie may argue on that.
Yeah, I don't know. Anyways, so this is the topic and the area that we've been focusing on for many years, and this is actually where I'm very excited about our recent innovations, and I hope I can share some of that excitement with you guys. So let's see if I can get this to go forward. Maybe not. Be a short talk then. So the heart's coordinated by electricity, and you can see here in the top left-hand corner every electrical heartbeat starts off in the sinus node, which starts off in the top chamber of the right atrium and goes as a wave across the top two chambers to tell them to contract as that wave passes. It then gets picked up by the normal wires of the heart and then runs down through the wire Purkinje system to tell the bottom two chambers sort of to ring themselves out. In the case of atrial fibrillation, all of that electrical coordination is lost. And you can see here the top two chambers have multiple reentrant circuits that are whipping around and running into each other's heads and tails. And it causes an irregular rhythm to be transmitted from the top chambers to the bottom chambers. Atrial fibrillation is, to hit some of the tropes for atrial fib talks, it's the most common cardiac arrhythmia. It afflicts in Canada 350,000 people, and it is responsible for 200,000 hospitalizations in Canada every year. Most patients have symptoms. They experience dizziness, they can feel lightheaded, they can feel palpitations, and they can even have syncope associated with it. However, independent of the symptoms when you have atrial fibrillation, the real risk comes from what happens in the chamber. As an atria is in fibrillation, it's not moving because it's contracting against itself. So in that non-moving upper chamber, blood can clot, and this blood clot can be dislodged and can cause a stroke. The risk of a stroke with atrial fibrillation is 5-fold increased on a global population basis. Now, in terms of treatments for atrial fibrillation, there's two main approaches. One is antiarrhythmic drugs. Antiarrhythmic drugs have been around since the 80s. The paradigm was actually developed in the 1980s, and it hasn't really changed much since then. 81% of the patients on antiarrhythmic drugs experience recurrence, and the drugs themselves confer an increased risk of death. So you're treating with a rhythm control strategy with something that can eventually cause a patient's demise. Cardiac ablation has had increased recognition over the last few years. However, you have to recognize too that there's no evidence supporting long-term efficacy. There's 2 times as many adverse events as a drug, and there's no registers showing improvement in clinically meaningful outcomes. So our treatment really needs to be refined. And that's the purpose of what we decided to look at. We wanted to look to see if we can intervene upon the substrate that causes atrial fibrillation. There are triggers which start it off, and there's substrate that perpetuates it. And our research is focused upon that substrate. And we want to move beyond simply suppressing the substrate with a drug or trying to destroy it as a catheter does. We started this off several years ago by looking at what's in the pipeline. So what's the public preclinical literature tell us? And we did a systematic review of biological therapies for atrial fibrillation. Callum did that in my lab several years ago. He's a co-op student who was here over the summer. And we looked at, in essence, atrial fibrillation in animal models, because those are the ones that would proceed to clinical trials eventually if they showed promise. I mean, there's lots of problems with this, obviously, publication bias and the rest, but we found 25 studies using a biological therapy to address atrial fibrillation. Now, a lot of these therapies were directed towards what you'd expect, right? Because an antiarrhythmic drug is basically targeting the ion channels of the heart. So the approaches try to increase refractoriness, conduction velocity, or even disrupting cholinergic signaling. Others, however, focused upon a new paradigm such as changing apoptosis, fibrosis, and even TGF-beta signaling. Oops, here we go. If you look at to test the principle whether a biological therapy can be effective, we looked at days spent in atrial fibrillation, odds of reducing atrial fibrillation, and effects on scar burden. And you can see that they generally favor treatment with the biological therapy. And so that led us to focus on 2 things, which we've been focusing on for many years before. One being fibrosis and the other being inflammation. Now, why, if there's so many preclinical studies, or several, I wouldn't say so many, but several, preclinical trials doing for atrial fibrillation. Why is it a challenge? Why is there nothing in the pipeline now? Well, a large part of it has to do with location, right? The atria is in the middle of the chest. Very difficult to get to. Delivery is a problem too. Unlike the ventricle, where you can do a coronary angiogram and put blood down the arteries that put your product down the arteries that feed blood to the heart, the atria has small caliber arteries. There's no way to really cannulate it. The walls are also really quite thin, so it's very difficult to inject something into the walls. Another real caveat towards the development of a biological therapy is that there's very few small animal models for atrial fibrillation. There's more genetic ones coming online, but the acquired models are rare and few and far between, and they don't really replicate human atrial fibrillation. And that's limited throughput of these approaches for many years now. Another thing too is sort of what's dominated the field. It's been an 80s treatment paradigm, okay? The treatment paradigm for atrial fibrillation has been based upon the idea we're treating atrial fibrillation. And so now we're looking at the change in the ion channels, and we're going to address that. We're going to address it with drugs or something that changes the ion channels. Well, let's recognize too that fibrillation is really an end-stage atrial myopathy. What addresses that atrial myopathy? That's something that's been diverting the field for many, many years now. Delivery technology has also been quite slow to improve. In fact, some companies have even pulled out of the field of delivering biological therapy. So that it's very difficult to actually deliver your product to a patient. Off-target spread can limit it as well. There's nothing worse than injecting something that has the potential to be oncogenic, right? And that would limit you very much. The one thing that's extremely important is quality, right? You need to have something that's rigorous, that's sourced, and scaling it to human doses. One great example is there's several papers that show microRNAs can influence atrial size. However, very, very difficult to scale it from a mouse up to a human dose. Very, very expensive as well. So that's the challenges that really are confronting a lot of clinical translation. We decided what we'd do is we'd focus upon post-operative atrial fibrillation. And to be honest, it's my favorite disease. It's become that way. And the reason is because you know when it's going to happen. I'll try to share some of my enthusiasm for it right now. 20 to 40% of patients who undergo open chest surgery or even minimally invasive cardiac surgery go into atrial fibrillation after the procedure. 10 to 20% of even non-thoracic, non-cardiac procedures have atrial fibrillation. The onset is stereotypical. It happens 2 to 4 days after the surgery. So you know when it's going to happen in that period. The episodes themselves can be self-limiting and recurrent, but don't forget, these are patients that are sick and they're healing from an invasive procedure. Their myocardium may be stunned and they're at risk right now. And that's when they're having increased demands from a very fast heart rate or even clots in the top chamber of the heart. So unsurprisingly, post-operative atrial fibrillation increases your length of stay, and it also will increase your global hospitalization costs as well. Some estimates are at least $10,000 per patient. Having atrial fibrillation after surgery also predicts bad things in the future as a subsequent increased risk for atrial fibrillation and also higher rates of stroke and cardiovascular death. Now, people have been trying to treat atrial fibrillation for many years, but the only treatment that's with good evidence for use is beta blockers. And essentially, that works by limiting the catecholaminergic surges that happen at the time of surgery and also limiting the ectopy after the surgery as well. Doesn't really do much for the substrate. Here's a great diagram from one of Stan Tell's reviews here. And you can see that there's preoperative factors such as age, hypertension, genetics that influence the atrial substrate. There's perioperative factors such as the surgery itself. And there's postoperative factors such as inflammation and oxidative stress. Many of these combine to remodel the substrate adversely, which causes the substrate for reentry. And others contribute to problems with calcium remodeling and increase in your ectopy that actually trigger the arrhythmia. The interesting thing that I find really cool about this is here's another figure from that paper, is this concept here, where you have pre-existing substrate, the surgery substrate, and the actual inflammation that occurs afterwards. And you can see here is the concept of the vulnerable substrate that increases. So you come in with a degree of vulnerability, and there's an AF threshold. What we do in surgery can put you over that threshold. And so you get into this, you go in and out of atrial fibrillation, and that resolves over those 2 to 3 days afterwards. And that's what we're trying to address in our approach. We think we can help take out some of this transient post-operative substrate, and maybe can help alleviate some of the surgical induced substrate as well. I don't think we're honestly doing much about the pre-existing atrial substrate, but that's something that we have to look at a little bit more. Now, the beauty about post-operative atrial fibrillation, from my perspective, is it's a predictable disease. There's lots of people with atrial fibrillation, like I talked about earlier, but we don't know when it's going to happen. It can happen episodically. It can happen to one guy once a week. It can happen to someone else once a year. You don't know. It's difficult to predict it. In this case, we know these patients are coming in for surgery. 2 to 3 days later, they are at risk. We know based upon who they are, who it's going to happen to. It's got a high impact as well. As I've talked about before, death, hospital stay, and even future events. The beauty of this too, though, is delivery. Target tissue is exposed before the disease develops. There's no better way to treat something than to prevent it. So and even prevent it right within the tissue where it's going to happen. The beauty of this disease as well is that when it's going to happen, these are highly, highly, highly observed patients. They're in the CSICU. They're on telemetry. We know what's going on with them otherwise. So it's a very controlled setting in order to document whether you're being effective or not. There's also, like I've talked about before, no clinical competitor right now. There have been other attempts and approaches, but most have been limited in terms of side effects, and none have shown tremendous evidence for efficacy yet. There's also no credible competitor in preclinical development that we've been able to identify. We're completing a market survey right now in order to assess this in a rigorous fashion. And so that's why we transitioned several years ago towards looking at whether what we can do in terms of fibrosis and inflammation, as Peter was talking about, whether this is effective in atrial fibrillation. And what we did was we focused upon the effector mechanism involved in our cells, because our cells have been shown to be paracrine producing, and the effector mechanism is the extracellular vesicles or exosomes that they produce. And you can see here there are a few exosomes are produced by most, nearly all cell types, and they're microparticles. So they're between 30 to 150 nanometers, and they're present in all bodily fluids. The payload itself is very cell-specific. So what goes in the cells, in the exosomes, such as the microRNAs or the proteins, is very specific on what cell is being produced, what is producing these. One of the first cardiovascular models that showed the effect of extracellular vesicles produced by a producer cell line was done several years ago, 2014, by Ibrahim, and it was Eduardo's lab, Eduardo Marban's lab, where they showed a comparison between extracellular vesicles produced by their heart-derived cell product, which is cardiosphere-derived cells, and skin cells. So they said, okay, well, we can have extracellular vesicles from one versus the other, and let's see what their effect is on post-infarct healing, because it's known that their cardiosphere-derived cells do promote post-infarct healing. And this is just one figure from Ibrahim's paper showing that one day after coronary ligation, the ejection fraction, which is a measure of how well the heart squeezes, was reduced from normal, which is 50% and up, down to 35% in all groups. And you can see here that if you got treated at this time here, I think it was actually the day before, but close enough. At this time here, you could see that those treated with the extracellular vesicles from the hard-derived cells did much better than those who got nothing, which is control, or fibroblasts. So that's and this is attributable in part to decreased scarring and inflammation. And so what we did was we focused on our cell product. And our cell product is the primary outgrowth from atrial appendages. You can see we've done this for many years now, and I've done many talks on this before. What we do is we collect atrial appendages from patients undergoing cardiac surgery, and they get this excised at the time when they go on bypass. And it's usually discarded. But in our case, what we do is we take this cardiac tissue and we're able to plate it and grow these cells, which we've called explant-derived cells. And here's a paper from that Seth did in our lab several years ago, showing what the effect is when you culture these cells in serum-free, xenogen-free media in a GMP cell manufacturing facility. And we do a lot of this cell culture in collaboration with Duncan Stewart and Dave Cortman over at UOHI. The beauty of using a cell manufacturing facility is that you're able to use these fancy cell culture hoods called biospheric units. And there's a diagram here, and you can see here that everything you need is contained within this microenvironment here. So once a biopsy from a patient goes into this biospherics unit, it's always at the same relative humidity and oxygen content as well. So it's constant physiological conditions for cell growth. And we do this using serum-free, xenogen-free materials because that limits variability in production, and it also makes it much more clinically translatable. They're also all sourced, which is a very important thing in terms of clinical translation. We use we use a lot of these cells because it increases our ability to produce cells by tenfold, and also increases the production of extracellular vesicles that we're able to attain by fourfold, which is just tremendous because it does take quite a few of these extracellular vesicles to generate a cell dose. Now, one thing that we've done in line with the literature too is you have to characterize your vesicles that you're able to produce and demonstrate that they fulfill many of the criteria that are required for an extracellular vesicle to be called this. And so they fulfill standard size criteria and things like that. Another thing that's very important though is you have to look at the surface molecules that are expressed by these cells and make sure that they do contain typical markers for an extracellular vesicle. And you can see here one of these arrays is very convenient because you're simply able to get a blot showing that they do express many of the markers that are found on extracellular vesicles. And most importantly, they do not show evidence for cellular contaminants. And that's sort of a key thing, because otherwise, I mean, you're simply taking a bunch of cells and grinding them up and calling that an extracellular vesicle. In this case, they do not contain these contaminants. We've also done flow cytometry in collaboration with University of Ottawa, and who have an excellent flow core. If you ever want to try it there, and they're able to do characterize the surface expression of markers on vesicles. And we find there's a fascinating concentration differential within our vesicles. And even cooler, we find that there's also a difference in terms of surface expression on vesicles with different diameters as well. This is something that we're still sort of looking at, trying to figure out what the importance of this difference is. We also went one step beyond that as well and looked at the expression of acetylcholinesterase on the surface of the vesicles. In one part, because it can be expressed on extracellular vesicle and doesn't necessarily have to be expressed on the extracellular vesicle. But the cool thing about it is we were able to show that it is expressed in our vesicle and that we're able to actually correlate the expression with concentration as well. And that gives us actually an easy way for us to be able to figure out what the concentration of our vesicles are before we administer them to an animal, because we'll just do this 15-minute test beforehand, and we'll be able to say, okay, with pretty good confidence, as you can see here, that we're able to, we have this concentration of vesicles within our injection. A lot of these details of this characterization is available on a EV-Track knowledge base, which is sort of the standard for the field now in terms of putting it online, what product you're doing before you publish. In terms of content, we've done nanostring profiling in Katie's lab. Thank you, using your machine. And we've been able to show that they do contain some fascinating collection of microRNAs at high abundance. You can see here on the left in terms of counts and the rank order, several promising ones. And when you look at the different themes that are predicted to be impacted by this mixture, you can see that it has some great things in terms of immune response, proliferation, and apoptosis. We've also done mass spec at the university on this, and we've shown that they contain proteins that are important in terms of being anti-inflammatory, and some that are anti-fibrotic as well. So, I mean, this has potential to say, okay, your EV product is able to, in part, reprogram what happens inside the cell through the microRNAs, and may even be able to act as a drug by delivering proteins to the microenvironment where they're administered. So I'm a clinician, and at this point in our characterization, it's like, well, looks promising. Let's see if it works. And we did this actually in a very rigorous way. We did this in collaboration with Stan Natel. And we wanted to be able to say categorically if this is worth investing any of our attention at all, okay? We developed a protocol. We spent actually almost a year getting this model to work and being reproducible. And we went through several iterations in terms of how we did this and how things would work out. We registered the protocol in the Open Science framework ahead of time, like Peter tells us to do. And we started in this protocol with 96 rats. And we did half female, half male. They initially were randomized to having application of talc or no talc. And talc is an irritant. So we opened up the chest, applied talc, and that, if you have talc there, it reproducibly produces pericarditis. And there are several papers showing this as well. A lot of them with pigs. However, there were recently people have been doing it more in rats. And we found that after tweaking it a little bit, we were able to get very reproducible results. We then randomized our rats to intra-atrial injection. So they got injected into the atrial muscle with either vehicle or extracellular vesicles. And then 3 days later, because we know that this is supposed to happen 2 to 3 days later, we looked using an invasive EP study. And our primary outcome for the study was AF inducibility. So a categorical binary outcome, able to induce atrial fibrillation or not. And I did every single one of these animals and was completely blinded as to what the treatment allocation was, because to be honest, I didn't want to invest any time in it if it didn't have any bearing. And it's actually really difficult to do an in vivo EP study. I mean, I do them all the time in humans, and it's really much easier. The way we did this, we evolved to it eventually, or we were forced into it because I didn't have any confidence that we were in what we were seeing, was we did an internal jugular, and we inserted a malar catheter down through the superior vena cava into the atria. And it's actually fairly tricky to get that adjusted just right so that you're able to pace and record reproducibly. You can see here on the right, we'll just talk about the talc plus EV treatment group here. You can see here that surface ECG, there's a P wave and a QRS afterwards. And then here's the intracardiacs in the high right atria, and then in the low right atria, because there's multiple poles along the catheter. And actually, the cool thing I just noticed on this ECG here is you can see there's a bit of ST elevation here, showing that the animal did have pericarditis. What we did, we measured obviously a lot of the standard electrophysiological measurements, but probably the most reproducible way to see if the patient had atrial fibrillation was to do burst atrial pacing. And that's what you can see here. It's the final bit of burst atrial pacing. As you can see in this representative image, the talc plus EV group did not have any atrial fibrillation after burst pacing. And here, talc plus vehicle, the intracardiacs show that the rat had atrial fibrillation, obviously detected in both low and the high right atria. And in this case, it was 8.6 seconds duration. So that was the primary outcome that we were studying. Our outcome for the study was that here, you can see it right here. Remember, this is AF incidence, the binary outcome. You have it or you don't. In our sham group, there's a baseline degree of animals that you can get atrial fibrillation in. This is pretty well known for these types of models. And you can see here that if you had pericarditis, there was about a 70% chance of me being able to induce atrial fibrillation. And this was reduced by application of application of EVs to about, I think it was about 25% or 30% here. And it comes down to a number needed to treat of 2, which is pretty good. So you had to treat 2 animals in order to get a significant reduction. You can see here that there wasn't much difference in terms of AF, or not a significant difference in terms of AF duration reduction. There's a trend, but not significant. And that's probably because of the low numbers of animals treated. Not animals treated, but animals that actually had atrial fibrillation in these 2 groups, in the talc plus EV and the sham group. When we looked at fibrosis, we used hydroxyproline. So we basically took the atria from some rats and processed it, and then looked for a global measure of fibrosis, which is reflected by hydroxyproline content. And you can see here, this is our baseline level in our sham group. Our talc plus vehicle group had an increased fibrosis, which was reduced by the application of extracellular vesicles. Now, we've talked about this being anti-inflammatory. Here's H&E staining of histological sections. Sham, this is what the picture is. Every blue dot here is a inflammatory infiltrate. In the talc group, you can see that it's increased, much more blue. And we're not just cherry picking. I mean, we're showing a good example of it, but we're not just cherry picking. You can see here that there's certainly an increase in inflammation in the atria, and it's throughout the atrial wall. And then in the talc plus vehicle group, it's markedly reduced, somewhat similar to the sham group as well. Here's the aggregate analysis, and you can see here there's a baseline for sham, increased in talc plus vehicle, and decreased in all talc plus EV group. We're not just looking at the cells themselves, but when inflammatory cells do get into it, do get into the atria, there are an increase known to be in inflammatory cytokines within the atrial tissue. So we looked within that atrial tissue using ELISAs and Luminex to see what the cytokines were that were present in the atrial tissue. And you can see here that in all groups, sham was fairly low. When you looked at straightforward pericarditis, which is talc plus vehicle, it's increased, and talc plus EV in all cases that we found here reduced the production of these prototypical inflammatory cytokines that you find within pericarditis animals. We also went on to characterize, using immunohistochemistry, what the inflammatory cells were that were found within the atria. We demonstrated that there's pericarditis itself increases the amount of neutrophils, cytotoxic T cells, and T helper cells, and these were reduced, again, uniformly with application of extracellular vesicles. This is a fascinating part here, and this is something that we thought we might see, but we didn't know for sure. You can see here that we looked at pro-inflammatory macrophages, and these are increased in the talc-plus vehicle group and reduced again with our extracellular vesicles. But the cool thing here is that when you look at the anti-inflammatory CD163 positive macrophages, you can see here that they're increased slightly in the talc-plus vehicle group, but when the animals were administered with extracellular vesicles, there's a marked increase in the anti-inflammatory macrophages. Now, we've shown that there's a anti-inflammatory effect here. The one thing that we were really curious about was what's driving this fibrosis effect? Is it inflammation, or is there potentially an effect from the vesicles themselves on fibrosis? And in order to do that, what we did was we used primary atrial fibroblasts. So we took the atria from volunteer rats, and we grew the atrial fibroblasts from the atria and used those in subsequent in vitro experiments, just to see if you expose an atrial fibroblast to an extracellular vesicle, does it have a direct effect on fibrosis? Not saying that it does, but it certainly adds, it might help to explain the effect that we were able to see. You can see on this graph here on the left-hand side, it just looks at fold change in cell number. If you expose the atrial fibroblasts to IL-6 or TGF-beta, which are known cytokines involved in the pathogenesis of pericarditis and post-operative atrial fibrillation, the proliferation is increased. This was decreased with application of extracellular vesicles. Population doubling time, which is another number of, or another way to measure proliferation, was similarly altered by application of the extracellular vesicles to an extent that was roughly similar to baseline. And EDU, just to hammer the point home, we applied EDU to the cultures as well, and we were able to show that the vesicles reduced the number of fibroblasts that had proliferated. I got a little obsessed about this, to be honest, and we went on again to look at, well, what's happening in terms of the cell cycle. So we used a fluorescent marker kit that we were able to use on the guava, and we were able to characterize what proportion of cells were in the different components of the cell cycle at a particular time after exposure to different compounds. You can see here at baseline, this is probably the easiest way to understand this diagram. At baseline, 60% of the cells were in the G0, G1 phase, whereas obviously 39 were undergoing proliferation. When you give it a drug or compound that's known to inhibit proliferation, 80% were locked into the G0, G1 phase. When we gave the cytokines that were involved in pericarditis, you can see that they were more proliferative in the S or the G2M phases. And when you gave the extracellular vesicles, it really is quite similar in terms of the proportions to baseline as well. So it's kind of neat how that portion of the G0, G1 is virtually identical after the application of the extracellular vesicles. There's quantification over here showing the different groups that serve, but this is the general concept that we were able to show. So quite cool. In any event, the conclusions for the study now are that a single dose of the extracellular vesicles delivered at the time of open chest surgery, so preventative before the disease starts, directly into this perfused moving area, which is the atria, has the potential to target inflammation of fibrosis that ultimately results in atrial fibrillation. So really a substrate modification strategy. Now, the advantages of the study are several. I guess I'm again biased, but anyways, it fulfills many of the circle and CAMRAD's criteria, which is quite important. I think we got sensitized to this in our systematic reviews that we did. So we tried to hit as many of these criteria as we possibly could. We also looked at the clinically meaningful outcome of incidence of inducible atrial fibrillation. So not duration of atrial fibrillation, but incidence. So actually a binary outcome. That's a pretty hard outcome to target. We also used a scalable GMP product using serum-free, xenogen-free materials. And that's important in terms of translation, showing that this is feasible and useful. We target many different mechanistic pathways known to contribute to post-operative atrial fibrillation vulnerability. Now, the cool thing about this approach too is that the producer cell lines can be amenable to engineering. So looking forward, if you modify your producer cell line, you could tweak your extracellular vesicle product towards whatever phenotype you want to influence. And that may prove beneficial in the future. We also have, with this approach, extremely local delivery. So we have high concentration within the tissue of importance, and that limits the prospects for off-target effects. And as you can see, there's many off-target effects that have limited other approaches as well when you give a systemic therapy. Now, there are also obvious limitations to the evidence. One known is that the repolarization or ion channels are very different from humans and rats. Yeah, we accept that. It's sort of, you have to start someplace though, right? Also, rats do not exhibit spontaneous atrial fibrillation. There's very few animals that do exhibit spontaneous atrial fibrillation. The only one that's published is actually horses. So that would be catastrophically expensive. So the field tends to rely upon this inducible atrial fibrillation as providing an indication of possible benefit. However, ultimately, you have to go on to other models as well to show that it can be uniformly applied. Effects on the preoperative atrial substrate, so established fibrosis, are extremely speculative. Don't forget, we just used application of talc to a normal middle-aged rat. So these had not had like years and years of hypertension and stuff like that ahead of time, which is what our patients experience. So we're not sure. I mean, the effect on the atrial fibroblasts is intriguing, but whether it applies, I'm not sure. And we also don't know what the effects on incisions or the systemic response to bypass is as well. We just couldn't examine it in this model. Rick would have freaked out if I tried to put them on bypass. There's also a ton of mechanistic questions. And I think this diagram sort of highlights where we are right now. We sort of know what's going on here. We sort of know what's going on here, but what's going on here in the middle? I mean, there's lots of interesting questions that we can ask about this. I mean, it's a complex multifactorial disease. I mean, for example, what cells uptake the extracellular vesicles? What effect does the extracellular vesicles have on other cells? Like, is there any off-target effects? Is it an off-target effect that's mediating our overall thing we've observed? I doubt it, but you can always play that game if you want to. What microRNAs or proteins within the vesicles are essential? There's lots of interesting candidates in there, but which ones are essential? Which ones are playing a greater role? I think there's probably a combination of effects from different microRNAs and different proteins being applied simultaneously. So I think it's going to be, I'm not sure we're going to be able to ever say that it's exactly this one, but I think there's lots of different players that are involved. Now, is there also a differential potency within the different subpopulations of extracellular vesicles that we have in our admixture? Don't know, it's quite difficult question to answer, but it's interesting based on the flow cytometry data that we were able to get. Now, can it be used to treat other forms of atrial fibrillation? Not sure. I suspect so, but I don't know that yet. And do extracellular vesicles from other producer cell lines have a similar effect? So could we take, for example, UCMSC, an umbilical cord mesenchymal stem cell, and simply use extracellular vesicles from that instead of having to rely upon our own explant-derived cells? Not sure. There is some evidence that there is a greater effect when you apply a heart-derived cell product to a cardiac injury model, but whether that extends to the extracellular vesicles that they produce, we don't know. So in terms of conclusions, extracellular vesicles represent a promising approach to modify inflammation and fibrosis in the atria, and the early data that we were able to provide supports applications where inflammation drives the outcomes. Now, work that will emerge over the next year, we've been doing a lot of work in this area, and we've done a comparison with other strategies to reduce post-operative atrial fibrillation, and that should emerge within the next year. We presented that at Heart Rhythm a few weeks ago. And we've also been able to demonstrate that there's a dose-response effect of extracellular vesicles in post-operative atrial fibrillation, and we believe that's probably a differential effect on different components within the mechanism that drives post-operative atrial fibrillation. So I think that's going to be a real cool bit of data that's going to come out as well. We're also engaging with patients to find out what their attitudes are towards implementing a therapy for their disease. And that should be a cool future avenue for exploration as well. And here's some diagrams that, some figures that, I guess pictures that Berenice was able to get in the last few weeks, showing actual uptake of lipophilic dye-labeled extracellular vesicles by atrial fibroblasts. And this one here is actually even harder to see, but you can see here that this is an RFP protein that was labeled onto the vesicles, and thanks to Katie, we were able to put that into our cells, and you can see here that it does co-localize with the atrial fibroblasts, so it shows that they are able to uptake these vesicles when they're applied. So I think it's just some cool movies to end off the presentation. In terms of acknowledgements, I'd like to thank people in my lab for a tremendous amount of work in this area, particularly Sandrine, who was able to push this forward and who's the primary author for much of the work. The cardiac surgeons that help us with donating the atrial appendages for which we're able to get cell growth. Duncan, Dave, and Sad over at UOHI who produce the clinical grade cells, and obviously Stan as well, who's basically our atrial fibrillation guru, who's helping us guide this study. And special thanks also to the Heart Institute and the University of Ottawa, who've contributed a tremendous amount of support in terms of helping us in terms of funding to do this and supporting some of the salaries in the lab through the endowed fellowships. Very much appreciated, and I'd be happy to answer any questions.
So this is really exciting, Darryl. This is fantastic, and lots of progress. And it really shows the evolution of the concepts, over time. And I'm glad that crazy suggestion of talc powder actually has produced, well, certainly produced the inflammation, and gave you a nice model to work in terms of proof of concept. Yeah. So. And very exciting, so in terms of the various funding mechanisms, we're able to get you, running, and of course now you're, really taking off, with lots of funding successes. So yeah, this is fantastic. Yeah, great opportunity. Of course, even I think commercialization potential, right? Your 3P grants speaks to that. So this is a great opportunity. And so I have lots of questions, but Rob Beanlands has a question. And exciting and innovative research, Darryl. Congratulations. How close are we to applying this to humans, and what would you imagine are the barriers?
Well, we're preparing a clinical trial, Rob. A phase 1, phase 2 clinical trial in order to assess the efficacy. A lot of the manufacturing issues, to be honest, are fairly routine. I had a meeting last week with Dave and Sad at UOHI on this, and I was amazed. We talked about, doing 25 patients in the first run in order to inject this product, and they said easily doable. we could give you enough cells to do this in a month. It's like, what? That's incredible. So, and we also have in Ottawa a lot of the expertise designing these types of trials and getting them approved. I mean, Duncan is done several trials in this type of area of cell application and stuff like that. So I think it's probably a great opportunity for us. We'll be applying for the clinical trial opportunity at the end of the month. Whether we get it or not, I'm not sure, but we're definitely going to be keep applying in it, and we'll try again in the fall if we're not successful in this opportunity now. Yeah.
So to declare conflict of interest, because I'm leading this major CEF-REF application, right? Bringing the heart, of course, atrial fibrillation is featured very prominent in there, and the CEF-REF is partnered with the BRIF, which is the biomanufacturing, sort of effort, that Duncan's leading, so we're coordinating too. So our grant is around 85 million, his is around, I think 70 million, so we're talking about major resources, coming into these domains. So make sure that you are plugged into that. The whole idea is actually to accelerate these type of opportunities. So this is a perfect timing. So let me see if there are other questions, and then maybe I can ask a couple of questions. So one is you kind of mentioned to a certain extent of these extracellular vesicles are fascinating, right? And they do actually have quite a bit of anti-inflammatory properties when they are applied in different settings, whether on even, regenerative medicine. And I know, certainly Duncan's group has looked at in intensive care patients, inflammatory lung injury, etc. So do you think that there is, I guess I always talk about, there are a lot of things, in the cargo for these vesicles. Is there a kind of a minimum essential, component, because if you know that, you can actually manufacture en masse, right? So you can then just kind of customize, those magic ingredients in a way, they are, sort of Darryl's recipe, and your secret, sort of formula, right? For all kinds of application. How close we are actually figuring out, I'm sure it's a combination of whether it's a microRNA, it's anti-inflammatory cytokines or signaling molecules. We find, when we doing these, it's actually a combination of everything, including fragments of DNA and those aspects. So what's your kind of a sense, or from what you seeing, and also what others are doing in the field? What is the likely kind of a content that would be so magical?
It's a super difficult question to ask, right? Because you think about the approaches for this. In order to study this, you have to modify the producer cells themselves to figure it out. And that subtraction itself might modify other things as well. And then, or you can just blindly put things into vesicles and give it a try and see if it works as well. And you saw the amount of microRNAs that are in relatively high abundance within these vesicles. There's a tremendous amount of them. Personally, I think it's going to be a mixture of them, and it's going to be quite a few as well. And it may not even become, for the short term at least, cost effective for people to be able to just make up a vesicle with a whole bunch of microRNAs produced, because that itself is extremely expensive, right? Stan was telling me about the one study that they did where they were able to show that injection of a microRNA in an animal model was able to attenuate fibrosis. But there's no way he could scale it, because all he could do is just get enough of the microRNA to try it in his rats, right? If you scale it up from a rat to a human, that's a huge amount that you'll need, and the cost is enormous. Now, those costs will probably come down eventually, but for the foreseeable future, if we have a cell that's able to naturally produce this, and we're able to do it like the guys were telling me in a few weeks at high abundance, then it kind of makes a lot more sense that this is much more cost-effective way of addressing the issue. We're working hard at trying to figure out which ones are important based upon what we've been profiling so far. And you have to do different ways in order to figure it out and be confident that you're not modifying your measure as well, right? So it's a challenge, but I think we're getting there actually.
It'll be fun. So we'd be glad to work with you, because obviously we're looking from a different model setting, but a lot of, I think, common, opportunities. And last question from David Burney. And here it comes. So fascinating work, Darryl. And the question is, can we use intracardiac voltage mapping as a surrogate endpoint in phase 1-2 studies? And Pablo Neri also, sort of has the same kind of question.
Tricky. I mean, that does mean another procedure though, too, right? So it's very difficult to get people to undergo another invasive procedure, particularly with a transseptal requirement for another transseptal as well, which has some risk to it. I don't do it, but it has some risk to it as well. Maybe Pablo can answer that and tell us if he's able to look at fibrosis with cardiac MRI. That would be a much easier sell for people than having to undergo a second procedure.
Yeah, I know you folks, are doing these, maybe even combine the kind of a non-invasive mapping, with MRI. I know there's quite a bit of advancement in that area. So that might be, sort of an opportunity, to look at some of those tools, right? Because I think it will be useful for the larger scale, right, inclusion, and good for target development as well. Having okay, so super. So lots of excitement. So no question, and so I think this is reflected by a number of granting agencies, enthusiastic supporting this. So I think this is really actually gathering momentum. Lots of I think exciting applications for this as well, not just the post-op atrial fib, even though this is a great clinical paradigm to work with. And David Burney just say this excellent work. So I think he just means that, you better work hard and get, really good at this.
I think this is great. I hope we can apply it to other forms of atrial fibrillation, but the beauty of this approach,
exactly.
Even if we fail, we can modify it and go back again.
Absolutely. So I think, this is really paves, sort of a whole new paradigm in terms of the approach. So this is fantastic. Thank you so much. So really kind of give us a little glimpse of the future, but, reflects the hard work you've been doing. And so all the best, and especially, in terms of one of the few, I guess, endangered species, right? Being a clinician-scientist. So we particularly celebrate your success, right? So thank you so much. And so next week, it's actually Professor George Wells, presenting. So there'll be also another fun session. So thanks everybody for joining us, and have a wonderful day. And till then, all the best.